This is Dr. Mike Story, dear and friend, because he used to work at UT Southwestern, and then he went to the dark side. Haha. So Dr. Mike joined the Mayo Clinic, and now we're switching gear again from MD to physics to biology. Dr. Mike, time is yours.
Thank you. You hear me okay? All right. So, yes, now for something completely different. I'm going to talk about the work that I did with Arnold while I was at UT Southwestern. You can see that I've moved now to Mayo Clinic in Jacksonville. So I'm going to show you the work we did there. All of the carbon work that we did was done at Canal. And some of the people at Canal are here, Angelica Faccoletti in particular, who helped us carry out these studies, Mario Siacha as well on the physics side. So we started this work because we were working diligently to get a carbon center at UT Southwestern. And we went through many hiccups and hurdles and you stop and goes. And so I finally got fed up and just said I was going to retire, and couldn't quite work that out, and mentally that I should retire. So I was fortunate enough to be able to join the team in Jacksonville, who were developing a carbon therapy center. So the work that I'm going to show you is work that as I said, we did at Southwestern, but we had to stop. We stopped predominantly because of COVID. But then with the changes in the political environment at Southwestern, that we got a hard stop. So I'm going to pick up these programs actually while I'm for the time that I'm at Mayo, and I hope that I can continue to collaborate with my friends and colleagues at UT Southwestern on this as well. So I'm going to talk about personalization of Hadron therapy, particularly carbon therapy, for radio-resistant cancers. And let's see. So,
don't worry, Mike. Since you mentioned my name, you have extra 25 minutes.
Okay. All right. Thank you. All right. So, this is the slide that was given to me by Laura Vallow, the department chairman at Mayo, and it describes it essentially a triage of patients who might be considered carbon eligible. So you start up here at the top with the NCCN guidelines, as the first speakers mentioned. There are certain sites where the NCCN guidelines suggest that, yes, we can use carbon. But beyond that, we start looking at high priority radio-resistant cancers like pancreatic or liver, kidney, and then radio-resistant subgroups within a particular tumor site. And I'm specifically going to talk about head and neck. And then you have, lastly, stage 4 malignancies, those where you'd like to consider immune activation or generating abscopal effects. But immune tolerance may also be responsible for some of the radioresistance that you see in these groups 2 and 3. So there's somewhat of an overlap in here. So I'm going to talk first about head and neck and the identification of subgroups, radio-resistant subgroups, how we go about that, and then I'm going to talk about pancreatic cancer and how there may be conditional vulnerabilities that we can take advantage of with carbon ions. All right, 2 approaches to personalization. The first the first thing is it may be specific to a given tumor site. So tumor sample availability. Head and neck, it's a great place because you have the opportunity to get tumor samples from surgery. And if you have those samples, then you can do all kinds of things, gene expression analysis, et cetera. I'm going to show you some of that data, for instance, from our studies. And the idea there is to try to develop bioindicators of a radiation response, or identify bioindicators for targeted therapy that you could combine with high LET radiation. So as I mentioned, tumor availability is a big deal for head and neck. It's a lot easier than other sites like pancreatic, where it's a very acellular biopsy that you get. And I'm going to show you some of our RNA sequencing data Another analysis form we're trying is actually isoform analysis. And then with pancreatic cancer, though, this is where you may have a conditional vulnerability where 25 to 30% of the pancreatic tumors have mutations in the DNA damage response pathways, those genes. And as a result, there's this conditional vulnerability there to heavy particles. And of course, that still leaves the other 65, 75% of patients, but who don't have these mutations in pancreatic cancer. But it gives you the opportunity to target some of the genes within the DDR pathway with targeted specific agents in combination with pancreatic cancer. So I'll show you some of that as well. All right. So from the perspective of head and neck, we had 38 head and neck tumor cell lines, and we agnostically divided those based upon their surviving fraction at 3.5 gray into resistance groups. So we had sensitive, moderately resistant, and very resistant. And I say we did this agnostically, as a result, for our radio-resistant group, out of 38, we only had 3 that were truly what we would consider to be radio-resistant. So we ran expression analysis against these 38 cell lines, and we came up with a panel of 37 genes that could put these cell lines back into their radiosensitivity groups with an 85% accuracy, but 100% for those that are in the radio-resistant cohort. Well, that's all well and good, but really, if you're going to use carbon, you really want to go after those that are more radio-resistant. So we tried to pare that down to only identify those that were radio-resistant. And as a result, we developed a 13 gene signature that could identify the radio-resistant cohort. And we really didn't care about the rest of them. So it was actually very inaccurate with the other groups. But we were able to identify the radio-resistant group of cells. Looking at gene expression analysis on those, using GC and Ingenuity pathways analysis, there were some interesting pathways that showed up. Cholesterol biosynthesis, but that's something that occurs in most tumors because they're constantly growing. There's a lot of membrane generation that has to be done. So you see a lot of cholesterol metabolism. But we also had 102 head and neck tumor samples. And within that 102, we had roughly 50 that we could divide into those who had no evidence of disease after 5 years and those who had local recurrence. And there's a very high overlap in the expression analysis, the pathway analysis between our radio-resistant cohort and those who had local recurrence as opposed to no evidence of disease. And there's some striking pathways in here that you would argue that, well, yeah, these are things you might expect to see. The predominant one being HIF-1 alpha signaling. And then after that, it was predominantly survival pathways, genes associated with proliferation, et cetera. So you see mTOR signaling, NF-kappa B activation. You do see cell cycle checkpoint control, et cetera. But doing the pathway analysis, looking at the leading edge significance scores, again, you see the same thing. You see this great alignment between the radio-resistant cell lines and those tumors that recurred as opposed to those that didn't recur. So we'll continue to explore this. We've published these data, but we'll continue to grow out our panel and look at other endpoints as well, because I honestly don't believe that just looking at gene expression is enough. So one of the areas that we're also looking at is isoform analysis. So with isoform analysis, genes have many. How can I say this? There are many forms of a single gene. So some genes may have up to 20 different forms of that gene, and those can be found in different tissues. They'll have different activities, and tumors will express one isoform over another isoform that would be found in the normal tissue, for instance. So we've been using high depth of coverage RNA-seq to look at isoforms, and we've identified 14 that appear to be associated with radioresistance. So I'm just going to show you one because it's really early days for us on this data. And that's the gene glutathione synthase. There are, I think there are 5 different isoforms, 6 different isoforms of that gene. And we've taken 4 of the cell lines, 2 that were on the moderately sensitive side and 2 that were radioresistant. And we looked at the expression of these isoforms based upon radiosensitivity. And you can clearly see this particular isoform right here. I think it's 717.8. And you see this clear distinction in the expression of this isoform. In the other isoforms, you don't really see a clear distinction. And if you look at just gene expression alone, you don't see any sort of difference in the expression of the gene GLS. Okay. So we then went into the ATCC data, the tumor databases, and we looked at first all HPV negative samples because we're interested in HPV negative head and neck cancers. And you can see based on the expression of that isoform in all HPV negative samples, there's no difference. If you look at radiotherapy or chemoradiotherapy, again, there's no difference. If you look at radiotherapy alone, you see a huge difference. This is a poor indicator of response, this particular isoform, when it's radiation alone. And if you look at the gene expression in the older days where we had probes for particular genes, you see in radiotherapy alone, there's really no difference at all. So when you have the ability to sequence the isoform itself, you see a clear distinction in here with radiotherapy alone. Now, that's obviously a lot of that is based upon the patient population within that group. How many head and neck patients get radiotherapy alone? Well, not that many anymore. Well, we also identified a number of novel genes based upon the latest data that's been generated for the identification of genes. Those genes that would segregate away that radioresistant cohort include members of the gauge family. Now, that's a rather recent finding, the description of this gauge gene. It's rather complicated. There are quite a number of varieties of the gauge gene as well. So it's right now it's a little different to parse out. People are still working on this, but the gauge gene family popped up for specifically gauge 12C, gauge 2E, other genes that included SPINK1, there are metabolic processes, et cetera, et cetera. The interesting thing about the gauge genes is they're not expressed in normal tissue other than, with the exception of testes, they're found on the X chromosome. And it's now thought that activation in tumors may be through demethylation. So, and in fact, gauge 1 and 2 are CD4 positive T cell antigens. So there's a lot that's unknown about the gauge family. And one of my colleagues is actually funded now to look at the gauge genes and their potential role in radioresistance and chemoresistance. So, I will only go through this briefly, but here are the carbon data for carbon versus X-ray data for 5 head and neck cell lines, and you, as you'd expect, you see this clear differential in survival. And here's all the data combined. And what I like about this is you can see that how carbon just tends to smash everything together. But one of the reasons we went through this exercise is because it's really my gut reaction to the kinds of, the methodologies that are used in treatment planning, particularly the use of cell lines for the limb plans, with the limb packages. So And I've struggled for most of my career with this concept of RBE. RBE can be highly variable, and that's of course how you might want to select cell lines or tumors for carbon. That would be based upon the radioresistance, and one measure of that would be RBE. But RBE can be anything you want. So we looked at RBE for these 5 cell lines. And so here's RBE at 10% survival. The numbers are reasonably close, but if you use the whole survival curve, use the mean inactivation dose, you can see they're quite variable, anywhere from 2.1 to 2.6. And so how do you pick out cell lines or tumors where the RBE might be so variable? So this is an area where we're concerned about how applicable is a generalized RBE in the intrinsic radiosensitivity of a tumor type. RBE says more about the low LET response than it does about the carbon response. What do we do now when we use very heterogeneous dose distribution? And fractionation regimens are moving to limited fraction numbers, larger fractions, doses, and limited fraction numbers. One of my pet peeves is the fact that LIM linearizes, although it uses alpha beta in its modeling, it linearizes beta. And there's a point, the survival curve analysis is actually biphasic, and there's a point where they begin to linearize the beta component, and that point where they linearize that is called the DT, this dose threshold. These dose thresholds can be as high as 30 gray. It's totally useless, absolutely totally useless. Then I would argue, why not use a model that doesn't linearize, where you don't have to determine DT? We showed a number of years ago that even for X-rays, when the dose fraction size gets high enough, that you will overestimate cell killing. And that's why they linearize betas to not overestimate cell killing. So we've been looking at a different approach, that being the conditionally repairable damage approach. It's a bi-exponential approximation as described here in this equation. It's been around a while, since 2015 actually. But what I like about this approach is that it gets to tumor control probability rather than RBE. And it does so looking at dose per fraction, the LET, the extent of hypoxia. We've now taken this and added tumor kickoff time and regrowth rates. But this is all it's just all modeling. But the nice point about this is, rather than using RBE, you can use RCE, relative clinical effectiveness. And by doing that, with RBE, everything has to be the same. Every component has to be the same. With RCE, you can mix and match fraction number, size of your dose, et cetera. And then you examine the tumor control probabilities, and you can then develop this RCE ratio. So here's a comparison where you can look at 3 fractions of carbon, 30 fractions of carbon, 3 fractions of X-rays, 30 fractions of X-rays, and then develop, use that in your model rather than using RBE. So this is all modeling, right? And all models are bad, but some are useful. And we're in the process now of trying to develop in vivo data so that we can validate or not this approach. And while we may not be able to necessarily abandon RBE, I believe anyway that the addition of RCE may be quite valuable actually. So we're doing that in the context of head and neck. So looking for the timekeeper. All right, so now I'm going to move to pancreatic cancer. So as I mentioned, there may be conditional vulnerabilities that are unique in this particular case to pancreatic cancers. These two figures came out of two papers, 2015 and 2016, where they performed whole exome sequencing in 109 pancreatic cancer cases. And they defined those mutations based on the commonality that of gene mutations that you see in pancreatic cancer, RAS, TGF-beta, P53. But they also looked at pathways as well, like cell cycle DNA repair, which is the green. And you can see there's a significant number of these tumors that have mutations in the DNA repair pathways. And okay. So was that 2 minutes or 5 minutes, Sarah?
25.
25, okay.
Correction, 25 seconds, please.
Seconds, okay. So we looked at, and then if you look here in this panel on the left, what was it, 25 seconds or minutes?
5 minutes.
5 minutes, okay, I'll be done. There are specific genes they found to be mutated, which include things like ATM. But what's important here are the FANK genes, FANK-D2, FANK-F, FANK-M. There's some RAD genes, XRCC4, for instance, and the BRCA1 and BRCA2, FANK-A. These are all genes associated, well, with the DNA damage response, but a lot of these are specific to homologous recombination. So we argued, can you enhance carbon therapy by targeting these mutations that are associated with DNA repair or replication stress, because these same FANK genes are also associated with maintenance of the replication fork. And so would charged particles hold a particular advantage over X-rays, and could we exploit that? So we know that with carbon ions, we generate these complex lesions. That's known. I'll skip through this real quick. But there are 4 pathways, 4 major DNA repair pathways. And the 2 that we've been looking at are non-homologous end joining and homologous recombination. There are 2 minor pathways, SSA, which also involves some of the HR genes, and then Alt-EJ, which POL-Q may have some role here, but we focused on the 2 major pathways. And in fact, Henning Willer's group showed that even with protons, if a cell line has a defect in a gene associated with homologous recombination, it was sensitive to protons. Okay. So even with protons, you can see this sensitivity. So we looked in 7 different pancreatic cell lines. And so here are the X-ray responses, and here's the carbon responses. This is gamma H2X foci, and you can see that the striped ones are the carbon responses. You see this significant number of gamma H2X foci remaining. Those are a marker of DNA double-strand break, the lack of repair of DNA double-strand breaks. All right, all well and good. So we took 4 inhibitors. An inhibitor to DNA PKCS, as non-homologous end joining, 1 to RAD51. We took ATM and ATR and showed that there are these clear, dramatic responses when you use these inhibitors. And this is one of our pancreatic lines here. So here's the X-ray response. Here's the response when you add the NU7441, the DNA PK inhibitor. You see the same thing with carbon. You see this enhanced response to the drugs. Now, BO2 with X-rays, you don't see that response, but you do see it with carbon. The ATM inhibitor, you see the same thing, the same effect, and with the ATR inhibitor, you don't see an effect for low LET. You don't see an effect for a low LET, but you do see it with carbon. So we now know that, in fact, some of these cell lines are sensitive to DDR inhibitors. They are sensitive to DDR inhibitors. I've got the SER values here, but we'll pass on that for now, because the real point of doing this exercise had to do with the position of cells within the beam. So if you take, what we did is we compared the the entry region with the spread out Bragg peak. And so here's the same data that I showed you on the previous slide, where you see the enhancement with the DNA PK inhibitor and with the RAD51 and ATR inhibitors. But when you look in the entry region of the curve, there are actually three lines right here. This is the entry region for carbon. It's the entry region for RAD51 and ATR. Unfortunately, DNA PK is way down here. So it suggests that, in fact, with carbon, you don't want to use a DNA PK inhibitor, because even those tissues, which would predominantly be normal tissues, you're going to have profound cell killing and likely adverse events. So based on time, I'll just say that we are testing patients for genetic defects. Because radiation oncology should start to specify some of the other genes that we need necessarily to look at. And we should use those to identify patients who would be carbon eligible based upon their mutations in DDR genes. And in fact, if they don't hold a mutation, they should still get carbon, because we can use a DDR inhibitor, particularly those associated with HR, in combination with radiation therapy. So, last slide. I'll just essentially I'll make the argument that the benefit for heavier charged particles over protons is biology. The biological uncertainties are greater for charged particle therapy, though. There are distinct advantages based upon this novel biology that need better defining and exploiting. And exploitation requires moving from population-based advances to individualizing therapy based on a vulnerability identified for a given individual. So I want to thank you for your attention. And these are my collaborators and funding sources.
Excellent. Thank you very much. Questions, please.
So thank you, Dr. Story, for this. I'm a medical oncologist dealing only with head and neck cancer. So I was really puzzled by your data, preclinical data on radio resistance. What we know in the clinic, as far as I know, I think this is the most advanced, I would say, translational research that has been done in head and neck. And this is based on the radiosensitivity index and the GARD index that, of course, has been, you know about this. So what I'm missing here as a clinician is always the transition between the cell lines and the clinic. And when it comes to the clinic, to me, at this point, the radiosensitivity index has the breakthrough that we would have loved to see. So which is your impression on that? And then I have a second question, which has to do with the future. As a clinical oncologist, we are always nowadays we're looking at circulating DNA. And today, the circulating DNA is used as like a marker of minimal residual disease. And here the question is not for radiation oncologists at this point. My point is, do you see the use in the next future of ctDNA as a biomarker, as a tool to predict radiosensitivity, or the contrary of it? Thank you very much.
Yeah. So I'm going to get myself in trouble on the first one. I've tried RSI in our head and neck. It didn't work. We tried it in a panel of 70 lung cancer cell lines. It didn't work. RSI works with a specific platform, apparently. It does not appear to work with RNA-seq as well. Now, I consider Javier a friend of mine, and he might, I know he would stand here and pound the table saying that that's not quite the case. So there are lots of problems with RSI. I'm not a big believer in it. You can still get that platform. It's the Affymetrix platform. And honestly, I think if it truly worked, we would have seen more data. I mean, it came out in what, 2009, something like that, right? I would think we see all these retrospective analyses, but we don't see anything in the other direction. So I'm still waiting on that. I know there's a clinical trial running now with GUARD, and I'm looking forward to seeing those results actually. So that's my point on RSI. Second point was the use of circulating tumor DNA, right? So pancreatic cancer, I'll use that as the example, right? When you get a biopsy from pancreatic cancer, there's so little material there. It's really difficult to, you're not going to do expression analysis on it, right? But if you use circulating tumor DNA, if you have a very, very limited number of genes that you're interested in, you may be able to pull that off. There's actually very little circulating tumor DNA with pancreatic cancer. It's much less than, say, for instance, lung cancer. But I do believe that's the route we have to go. But there's another issue there. So, for instance, with pancreatic cancer and these DDR gene mutations, you have to presume that they're somatic mutations as well. If they're germinal, well, then you have a problem because you're going to have issues with the normal tissue anyway, because the normal tissue carry the same mutation. So,
great. Thank you. Okay, so if there is no more questions, we will close this session and then we'll just go a few closing remarks here, because we are between the break and information resources. So thank you very much to all the speakers. This was awesome, excellent session. I will briefly bring up three brief marks, here that we heard, during the introduction, during the speaker discussions here. So the first one was the importance of the different biological modelings in Hadron therapy, especially for carbon ion therapy. So the first speaker, she was mentioning this, that they use a treatment planning system which has both LEM and MKM in it. And I just wanted to stress out that this is not just for fun. This is like super, super important, because if somebody wants to do an international clinical trial, then the medical doctors, they really, really need to know what they're talking about. And when we tell them and show them physical dose distribution, well, they're not physicists, so they'll say, show me something that I understand. So then we need to show them a biological dose distribution. And then which biological dose distribution? The Japanese people and the Asian people are talking in MKM language, the Europeans, talking LEM language, and now you have a problem. And so in other words, if you want to do a worldwide clinical trial, you better, have all these medical doctors on the same page. So my just message here is that this is super, super important that the CNAO folks, manage to actually convince, the treatment planning system vendors that they're able to put in, both of these models. And then, they can show the results, to one medical doctor, to another one. And then once they agree worldwide, then they can proceed. So this is super important. Then I have one more comment here, which was about data. So data, I would like to stress out that this is super important in my mind, to generate maybe registry protocols, which could be nationwide, worldwide, basically, where people will dump into this registry protocol, patients that you treat, and then that would allow you to, based on ethical committees, to actually mine the data, what you've done. So anybody who comes up with new ideas, we are encouraging to generate a registry where you follow these patients and you have these data available, and then you can mine the data and you look at the data in an intelligent way. So that was the second comment. And I have one more, which was, you guys are here because you love Hadron therapy. So somehow you are all engaged and you know what you're talking about. But there's like 99.9% of other medical doctors who might not have a clue about Hadron therapy. So I want to just bring up that these forums here are awesome. This is fantastic. And I think, you can get it to the awesome to the second power. Maybe if you invite, some of the referral physicians, the people who actually, seeing the patient and have no clue what to do with the chordoma or chondrosarcoma or something, and they are in the darkness and they might not know about Hadron therapy. So education, spreading the message, bringing and exciting your referral physicians, and then asking them about being part of this, inviting them here, take the message back. I believe would be a nice next step in the next events like this. Okay, these were my conclusion remarks, and my friend has more.
First, we can allow response. If there's anyone that wants a response to these comments.
I'm so clear.
So my comments is I like very much the last talk where we need to really find molecular markers for radiation response. But I think also we need to move in the direction of immune response. So carbon is becoming, well, in some labs, it's becoming obvious that it does trigger an immune response. X-rays and protons are immune suppressive. And this can be a big game changer because the immune system plays a major role in many, many types of cancers. If we are treating an immune cold tumor, it's a lot different from treating an immune hot tumor. And it would be really nice to understand how this works. Okay, there is now 6 FDA-approved ICI, so inhibitors. Carbon can be shown potentially for others. All right. This is one thing. And then the second thing is we have to keep in mind the lymphopenia. So radiation has been shown to be detrimental in lymphocytes. This is something that plays a major role also in the immune response. If we can reduce the amount of blood that's irradiated, this would be a big advantage for many things, especially for carbon, for example, and especially for protons. I think this follows very much the talk from Mike, which I really liked a lot of these markers, these ideas. I think radiation resistance is not the only marker, of course, but, and I completely agree, RB is a terrible parameter. I think we need to move on from that, but I think we have to look at other things.
Jota?
Thank you. And just to respond on your comment, I think it's also important to go to the doctors and have the doctors here. And that's what we are trying to do today, actually. And I want to thank first Antonio Capicello that brought us in contact with the medical community. He took it on him. He brought us in contact with the head of the medical school, with AHEPA, with INU, with Hippocratio, all the hospitals. Of course, Papageorgiou, we always had contact and cooperation with Dr. Bukovinas. Now we have new people here. And actually, I'm really very pleased that we are here in the Aristotle Medical Forum, that is the medical community, and we have the opportunity from interaction. But as Sotiris also said yesterday, now the doctors have to step in and, and yeah, this is my question. At the end out of this workshop, I want to know, do we want to have hadron therapy in Greece, either proton therapy or carbon therapy or both? So this is a question to the doctors, and we are here to, push and pull and everything, but up to a certain point, the doctors must step in, and we hope to come with a 2 pages white paper that some prominent people, some hospitals will sign, and then we'll see how to go from there.
Thank you very much. Exactly. And then I think, we can finish this session here by actually reminding you guys that once HITRI is over at 6:30, there is still a session at the Aristotle Medical Forum, 6:30 to 8 o'clock, which is about AI. So I think it might be fun, if you guys don't just go and eat dinner right away, but you might, come next door to the last session of the AMF there. It might be fun. So thank you very much. This was awesome, and enjoy your break.
Just 1 more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.